Good evening. Hello, everyone. Thank you all for joining us tonight to discuss non-operating room anesthesia in the COVID-19 era. Let's start as usual for those of you who are frequent attendees for our webinars with the legal disclaimer. While you're reading that, I have a couple of housekeeping items just to go over with you real quick. Each one of you have a control panel. You can see that in the right upper corner of your screen. Please use that for various functions, like you can use the questions box to enter any question, and you can do that during any minute of the presentation. We'll get that. We'll try to answer it at the end. We're going to have a Q&A period toward the end of the presentation. There's also a chat box out there that you can use as well. If you have any technical difficulties, please write a note in the chat box. Our staff will be there monitoring it, and we'll be happy to help you to resolve that issue. We do encourage you to submit the questions again today, or if you want to send it to the email, that would be okay as well. Please remember that this is listen-only mode for attendees, but we're happy to hear from you through the chat box, the question box, also through the email. Well, if you haven't done that recently, I would encourage you to visit our website. We have recently posted 2 statements. This is one of them, the resumption of ambulatory anesthesia care as our nation recovers from COVID-19. We issued a statement on that, has some useful information. We're going to discuss a couple of those items in today's webinar. And the very latest statement that we issued, because there was a lot of buzz going around testing and it's still going on, as many places are going back to elective surgeries. A lot of buzz about what to do about testing and what it means and so forth. So we issued this statement regarding testing before ambulatory anesthesia. If you haven't heard yet, because of COVID and related travel ban issues, we had to cancel our in-person meeting. However, we are leading the industry in medical conferences and moving to virtual conference. It's nothing like I've ever seen before. It's not like a regular webinar or Zoom like this or so forth. It is a true virtual experience where you're going to be able to not just attend the lectures, but you can also have a side conversation and chat, just like the way we do it in a conference hall with colleagues and friends or like interested individuals in the same topics and so forth. You'll be able to visit the virtual exhibit floor with exhibitors and sponsors. There's a lot into it. There's going to be a event app attached to it. We will be recording that event as well, so your registration fee will cover both. Whatever you attend during the weekend, and if you want to watch it again or see it later at a more convenient time for you, you can do that as well. It's all for the same price. So if you haven't heard, we do have a lot of benefits to our members, and I encourage you, if you are not a member, I know the majority of you are members, but if you are not, please visit our website. We'd love to have you with us. There's a lot of networking opportunities in our society, a lot of mentorship, a lot of activities, opportunities to serve in committees and develop your leadership in the field. Many of our members received help from senior colleagues in getting reference letters and recommendations for their academic appointments. If that's one of your aspirations, there's just a lot to offer there. And for the mere fact of getting a huge discount at the annual meeting, our membership is way worth it. So please join us and enjoy all these membership benefits. And don't forget to join the forum where you can interact with your colleagues from around the country and around the world. We also have recently issued the opportunity to become a Samba Fellow. This distinguished status only given to those who have fulfilled certain criteria. And please check it out. You might be eligible, or you might need a year or two to fulfill some of the criteria, and that would be another worth it membership benefit for you. The board have issued this COVID-19 resources webpage for you. For members and non-members, this is not the time to look at membership and so forth in this era of COVID-19. So it's open access for all. So please share freely and openly with all your colleagues and friends who wants to learn more about COVID-19. and these webinars also will be there. So we had many webinars in the past. The recordings and the slides are there on this website. And tonight's webinar will also be posted, I believe, by end of business tomorrow or so. Video and slides as well for you to review. And if you missed a slide or two, you want to get some more information there. We're continuing with our webinar series. And next Monday, we will have number 6. And this one is going to be all things COVID-19, Samba Town Hall. So for that, we need your help. If you have questions that we have not addressed in our previous webinars, or still you're not convinced, or you want to hear it one more time, or you want to learn more about it, or something that you're facing, please send it to us now. The earlier I get the questions, the more opportunity for me to identify an expert in the area to invite to be among the panelists who will address this webinar and take your questions. We'll also be accepting live questions from the audience through the chat box or question box if you are interested in doing that. If you want to send us the questions now, please send it to this email at the bottom, info@sambahq.org. With that, I would like to introduce tonight's speakers and panelists. We have with us tonight Dr. Mark Phillips, who's going to be talking to us about COVID-19 and anesthesia for GI. Dr. Phillips is Associate Professor of Anesthesiology and the Medical Director of GI Endoscopy Anesthesia at the University of Alabama at Birmingham. Also with us tonight, Dr. Neeraja Rajan. She's going to be talking to us about COVID-19 and ambulatory pediatric anesthesia. She is Associate Professor of Anesthesiology at Penn State Milton Hershey Medical Center, and also the Medical Director at the Hershey Outpatient Surgery Center. Not only that, but she's also a member of SAMBA Board of Directors and the chair of the Committee on Statements and Guidelines. We have also with us as a panelist Dr. Hinda Abramoff, colleague of mine. She is the section head of anesthesia for interventional radiology in the Department of General Anesthesia at Cleveland Clinic. I should be happy to take any questions that you might have regarding COVID-19 and anesthesia for interventional radiology. With that, last and believe me, certainly the least, yours truly will be talking to you about COVID-19 and anesthesia for bronchoscopy. For those of you who are new to us and do not know me, my name is Bassem Abdel Malik. I'm an anesthesiologist at Cleveland Clinic, serving SAMBA currently as SAMBA president. I'm also the director of anesthesia for bronchoscopic surgery at Cleveland Clinic. So let's go through a conflict disclosure to start with. As I said, I'm SAMBA president. I'll be discussing in my presentation a couple of SAMBA statements. I do receive a small royalty from the sales of these 2 textbooks. Some chapters of those address parts of the topic we'll be discussing today, which is anesthesia for bronchoscopy. Whenever I talk about bronchoscopy, it's a topic near and dear to my heart. It gives me a lot of pleasure to talk about it and discuss with you the things that we have learned through the years and what we've learned just in the last couple of months about COVID-19 and how to manage anesthesia for bronchoscopy in the light of what we know about this horrible disease. Well, I had the privilege of being part of planning this bronchoscopy suite at Cleveland Clinic. My colleague, Dr. Gilday, and I kind of had the idea to build this since 2007 or 8 or so, and we end up having it open by 2010. As you see, a modern, well-equipped suite, and we have 3 rooms there. So we've been very busy since we started. In a busy day, when we have the 3 bronchoscopy procedure rooms open and functioning, we do about 17 to 18 cases a day. That's about 3 days a week. And 2 days a week, we have 2 rooms open. We do about 12 to 13 cases in those days. That volume has been cut down less than half when we start doing elective surgery. A lot of the things that we do are urgent and emergent, and those we could not stop. So they will not be discussing the proper talk about anesthesia for bronchoscopic surgery. That's not the focus. We'll talk about COVID-19 as it relates to that area. However, if you're interested in learning more about the topic, there are many publications out there. Many of them are from our group and also from Dr. Sharkis and her colleague at MD Anderson, where they have a very active and busy service there doing great work. So before we dive into COVID-19 and how it impacts what we do, let's review a couple of slides about the virus and what we know about it. We have discussed those a couple of webinars ago by Dr. Sharif Mossad when he presented what he knows about the infectivity of the virus, transmission and treatment and so forth, as he is the infectious disease specialist. Well, it's a single-stranded RNA virus. It is said that the main mode of transmission is droplet, and it goes to a distance up to 6 feet, hence the social distancing of 6 feet that everybody talks about. It is claimed also to stay viable for hours and in some instances in certain surfaces for days. However, the way the virus is spread and all these people that got infected with it, it doesn't really fit into the droplet transmission narrative. That's why a lot of people suspected the aerosol transmission mechanism. Aerosol, as you know, comes during coughing, sneezing, breathing vigorously, and so forth. And that one those droplets can travel up to 300 feet because they're of smaller size, not like the bigger droplets, but the aerosols could travel up to 300 feet. People still say that this still requires additional investigation to confirm that. But again, what we have seen clinically kind of fits into that scenario. What adds to the issue with the infectivity of this virus, the so-called SARS for severe respiratory syndrome, coronavirus 2, to separate it from the SARS coronavirus 1 that did the initial SARS a few years ago. So SARS-CoV-2 may be transmitted from asymptomatic carriers. Also, for those who are symptomatic, before they even become symptomatic, they can shed the virus and infect others. The virus testing is not perfect, as you all know. The range of false negative can be up to 30%. It depends which test and the prevalence of the disease in that area. Another concept that we start hearing a lot about lately is AGP, aerosol generating procedures. Because we talked about the infectivity being a droplet transmission versus aerosol transmission, and a lot of folks believe in the aerosol transmission theory, just looking at how bad the infection was and all these folks who got infected with it. This systematic review that I've referenced there in the bottom enlisted a few procedures that are considered aerosol generating procedures, including intubation, extubation, bronchoscopy, endoscopy, ENT surgeries, especially sinus surgery, and transnasal cranial surgery that many of us participate in, and also tracheostomies. Not only surgeries are aerosol generating procedure or procedures that we do like intubation, extubation, but some of the ventilation modalities that we use could be aerosol generating, like non-invasive ventilation using CPAP masks, especially if the CPAP mask doesn't fit well, there's a leak. High flow nasal oxygen. If you were with us at the last SAMBA meeting, I gave a presentation on that. We're going to see a couple of slides later. We're going to see a couple of more information about that. Not only that, but just the mere using of nasal cannula. If you use it at flows at about 5 liters or so, it is said that the air dispersion distance could reach up to 3 feet from that. So, as you all know, we all stopped elective surgeries and our volumes went down, and we only did the emergency elective surgeries, emergencies and semi-emergent or very urgent cases. But now, as we start to see some hope, as the numbers of affected patients start to come down, hospital admissions are going down, as well as the mortality, we start to think about how we can go back to reopening our closed ASCs, how to revamp our volumes to get back to do semi-elective and elective cases. So we kept doing emergencies and urgencies. Now we're going to try to look at how we can fit into semi-electives and elective cases. Anything that could wait, we postponed. Anything that could not wait, we did. The SAMHSA statement has a lot of important information there. I summarized a few points here for you. We talked about how we need to do that in coordination with our local governmental officials and health authorities, because they are the one following the trends and the numbers and seeing in our communities. When they start seeing the numbers continue to go down in all these areas, and for our part, we look at the availability of PPE, availability of hospital beds, as well as the resources, just in case if we get a second wave or there's increasing number of infections. Only then we can start doing elective cases. We talk about when we do that, we recommended a few things: maintain distancing between patients and visitors, limit visitors to one or none if possible. We continue to screen patients and providers for symptoms with temperature monitoring and a questionnaire about symptoms. Avoid crowding areas, especially the waiting areas. Encourage the use of masks in public areas as well as clinical areas. PPEs, we talked a lot about that in prior webinars, and also scheduling procedures to allow time for droplets to settle during aerosolizing procedures. The American Association of Bronchology and Interventional Pulmonology, AABIP, have issued a statement earlier at the stage when we stopped elective surgeries. In March 19, they put out this table, which was very helpful then and helpful to us now. We're helpful then to see which bronchoscopy cases to consider postponing and which one that we have to proceed regardless. So emergent bronchoscopies, as you see here, severe or moderate tracheal stenosis, central airway obstruction, massive hemoptysis, migrated stent, they cannot wait, have to be dealt with immediately. Urgent bronchoscopies are the one that depends on how urgent the situation is. Very urgent, proceed. Not so urgent, we'll move it to the non-urgent or the elective bronchoscopy type of deal. And it's helpful now when we do testing pre-operatively, as testing capabilities became more available. If we have somebody who's COVID positive, if they are emergent situation, they proceed anyway. If they are not, then they should get care first, get treated for the COVID, then come back for their non-urgent or elective bronchoscopy. So that information was very helpful. They also, at the same time, the same group almost published an article talking about what to do when you have a COVID-19 positive patient coming for bronchoscopy. They recommend using negative pressure procedure room. They also recommend limiting personnel, using full PPE, use disposable bronchoscope if available. You all have seen our disposable intubating bronchoscopes. Pulmonologists also have disposable bronchoscopes that are operating bronchoscopes. They're a bit fatter than ours, that have a big working channel, allow their instruments to go through and do their procedures. Avoid atomizing patients' airway, and they also recommended avoid jet ventilation. We're going to have more to talk about that in the next few slides. So then when we start doing that, people start to come up with protocols for testing, and questions start to arise. How are we going to handle testing? Well, what should we do about testing? And therefore, your society, as we try to always be helpful to you, issued this statement on COVID-19 testing before ambulatory anesthesia just a couple of days ago. If you have not had a chance to see it, please visit our website to read the whole statement. But why testing? people say, well, what's a big deal? I mean, why are we testing right now? And I understand that it's not a perfect situation. The tests may be false negatives, false positives, and so forth. They may not be readily available in some areas, but we encourage you to try everything possible to get those tests available for your patients. There are many benefits of testing patients before surgery, for example, and I borrowed this slide from my colleague Mark Taylor at Cleveland Clinic. Benefit to patient: guides operative time, decreases perioperative risk. There are reports about increased morbidity post-operatively if we operate on COVID-19 positive patients. It also creates safety perspective for the patient, and this one is extremely important. It is not because that we opened our doors, people are gonna rush in. I've read numbers like 30% or so of patients are afraid of getting into medical facilities. They do not want to catch COVID. And also, I heard that 40%, there's 40% decrease in emergency department visit for cardiac events. I want to hope that this is because there's actual decrease in events, but that's not true. And just people are staying home and afraid of going to emergency department that they might catch the infection. And I hope that there's not a whole lot of people dying because of that. So when we do something like that, it creates sense of safety, makes patients are comfortable. They know we're testing everybody, we're doing everything possible to keep our facilities COVID, I would say, safe versus COVID-free, as we learned in the last webinar from Dr. Michael Hicks. Benefits to caregiver: that's physicians, nurses, the teams, technicians, there's therapists that are working with us. It allows the team to manage cases appropriately. Also, drive PPE utilization. This might not be a huge benefit in bronchoscopy because it's a aerosol generating procedure, and we all the team members will need to wear N95, for example. But in non-aerosol generating procedure, you could save PPE for the rest of the team. Only the anesthesia team would be requiring to use PPE for intubation and extubation and such. Also, benefit to the organization: cohorting. You would find out what's the prevalence in your population, in your area, in your patient population that comes to your hospital, and obviously for risk management, and I do not need to say more about that. So in our statement, we recommended a few things. We said that you should test within 24 to 48 hours. If that's not possible, make it 72 hours to kind of work with the logistics in your area, how available the tests are, where are being done in the same facility or different facility, and so forth. Obviously, symptomatic patients who screen positive or test positive should be referred to appropriate resources and have their elective procedure postponed. Obviously, if it was emergency procedure, they should proceed regardless with the precautions we mentioned earlier. But here's the thing: this point, not a lot of people talk about, which is once the patient is tested, we should talk to them and let them know that they should be careful from now on until they show up for their surgery. They might want to self-isolate and decrease any opportunity for exposure, because the test is one point in time. It tells you that this patient is not negative at the minute they were tested. Now, if this was done 3 days prior, then you have 3 days the patient could be exposed to a virus. And also remember that there's false negative. So we still have to be careful when they come to us, but continuous screening as the 3 days, that when they come to you in the morning of the procedure, you still do the temperature, you ask them the questions. In case if we have false negative and now the symptoms are showing up, then we can catch them then, and we still deal with them as if they are asymptomatic carriers afterwards. So patients who have negative tests and continue to screen negative till the morning of the surgery, or the time of the surgery, they can proceed. A lot of people are talking about antibody testing and so forth. So we made sure to put in our statement that antibody testing is not a triaging tool. We learned from Dr. Musad a couple of webinars ago that IgM, IgG, we do not know if it's protective or not, and there's not a whole lot of testing available from this category. I know the capacity is increasing and becoming more available in certain areas, but this is not the test we're talking about. We're talking about the virus test for pre-operative evaluation. So with that in mind, we talked about all this information. Now, what have we done differently in our bronchoscopy procedures to accommodate this new pandemic that we have? We have been using a lot of supraglottic airways for certain procedures like managing subglottic stenosis and or mediastinal staging. Now we try to minimize that because there are potential leaks. And in the past, we used to tolerate if there is a small leak, patient is ventilating adequately, we used to tolerate that. But now if we have leaks like that, we immediately change to endotracheal tube. When we use endotracheal tube, as you all know, we use 8.5 or 9 big tubes to allow room around the big fat operating bronchoscope or EBUS scope so as we can ventilate the patient. And that works well as well. Excuse me. Other practice changes, some of us adopted the rabbit induction. If you notice, I did not put the rabbit sequence induction because it's not really the whole cricoid pressure and this and that. It's just finding the right dose of anesthetic, followed immediately by the right dose of muscle relaxant. And some of us start to go back to succinyl choline so they can avoid mask ventilation, which is another opportunity for aerosolization, and then go ahead for intubation right away. Use of video laryngoscope has increased because video laryngoscopes first increase your first pass success. That's one thing. Second, it separates the face of the intubator from the face of the patient, and thus increase safety. A lot of folks are talking about extubation. My point of view on that is not a good idea. It just leaves a patient with anesthesia without protected airway, risk for aspiration. If they're deep, you're going to have to provide high oxygen flow, and we talked about how that would be aerosolizing, or you have to do mask ventilation or emergency re-intubation. All are aerosolizing procedures that could increase risk. Try to use techniques that we always use in ENT to avoid cough and bucking and so forth to decrease aerosolization. Those work very well. Folks talked about avoiding awake intubation when possible, but there are situations where we still need to do that when somebody had a flab or radiation, ENT flab or radiation and such. When we do when we need then we need to not to atomize or nebulize local anesthetic, perhaps use other techniques like topicalization with nerve blocks. And I've used successfully recently lidocaine lollipop, a technique that I've never used for a long time, where you wrap a little gauze around a tongue depressor, soak it with viscous lidocaine, and insert it by the anterior tensolar pair for a couple of minutes on both sides, and that provides great topicalization. Use disposable flexible intubating scopes, and proper sedation obviously is important. Jet ventilation, the manual one here to the right and the automated machine to the left, both are considered to be high risk for aerosolization. So if we use rigid bronchoscope, a lot of centers, especially in Europe, use the jet ventilation as the ventilation technique of choice. We did not have to change anything because we have been in the past using this closed circuit ventilation, where we hook up the circuit to the side port right here, and you notice we have wet gauze here to pack around the scope, and all the orifices of the operating bronchoscope are covered with rubber caps. This way we can do pulse pressure ventilation with the bag. There's still a little leak, but much better than other techniques and works very well and safe. I've been doing that for so many years in our population, and we do a lot of rigid bronchoscopy, being very, very successful. High flow apneic oxygenation. This is the system. It provides, here's the humidifier, and these tubes have wires in it to keep it warm. So it provides humidified, warmed up oxygen flow up to 70 liters per minute. It provides oxygenation as well as ventilation while the patient is sick, because we use that with muscle relaxation as well. and was very, very successful and helpful in a lot of ENT procedure and some bronchoscopic procedures, but it has a lot of issues. It has high flow, up to 70 liters, so it aerosolizes and goes through the nose, so nasopharynx, and nasopharynx is known to have higher viral load. And you do not have that protected airway when you do the bronchoscopy to control the amount of aerosolization that happens. So that now is being avoided, and we tend to use tubes instead. We can minimize coughing and retching during and after the procedure. So during the procedure, we will use deep anesthesia and complete muscle relaxation regardless of the airway. LMA tube or supraglottic airway, I meant, or endotracheal tube is still muscle relaxation, and obviously deep anesthesia with that. And with induction, I tend to use like 100 mics of fentanyl or so, because almost all these patients have this cough afterwards because it's so irritating to the trachea when they do this procedure, get the biopsies and so forth, so dilate and whatever work they do in there. So they keep coughing for like about 20 minutes or so. We can minimize that. It's almost impossible to avoid it totally, but at least decrease it by giving a small dose of fentanyl up front. Also avoid retching by proper post-op nausea and vomiting prophylaxis during the case. That will help afterwards. If you know me, you know I like a little bit of controversy every now and then. So here is the so-called intubation or aerosol box. A lot of people have been talking about this since COVID started because they want to avoid being exposed to the aerosolization during intubation or extubation. It looks cute and it sounds nice, and people who there's a different formats, different versions, different designs. I think the one big advantage of having this one is that people feel good about it. They feel like they've done everything they could to avoid being exposed to aerosolizing infectious material, and that's about it. But if you think about it, first, it has not been proven to be safe, but who cares about being proven now? In the era of COVID-19, for the last couple of months, there's not a whole lot of evidence-based medicine. Most of the publication there are case reports or a cohort without control or consensus statements or expert opinions. But logic and common sense can help us to look at some of the issues with this box here. Is that it makes the intubation awkward and cumbersome, and it might end up making it longer. Well, our goal is to secure the airway as soon as possible. And can you imagine what happened if you encounter difficulty intubating while they have this box in there in a way? I imagine somebody will throw it away, and that may spread things out in the room and so forth, and rush to secure the airway. And as you do that, you may have to do some more ventilation, or if we have relaxed our PPE because we thought we are protected from exposure from this box, and now we have to do intubation in usual fashion emergently because we had difficulty intubating, that would be another issue. It adds a huge surface. Look how big this thing. So here's another surface in the room where virus can sit on and stay alive for a while. And if we didn't catch the infection during the process, during sterilizing and cleaning it with wipes and so forth and stuff, we might end up. This one is kind of simple, but I've seen others with curves and stuff and using old incubator boxes to do that. So think about these things if you decide to use one of these aerosol or intubation boxes. A lot of my colleagues in airway management circles do not like this box for those reasons I mentioned and more. We're close to the end. A couple of more slides here. Bronchoscopy and the procedure of sedation. Many of these patients are home oxygen dependent. Even if not, they typically require many liters of oxygen supplementation. You get my point here. There will be some more aerosolization happening if we do procedural sedation or moderate relief sedation for them. They also frequently cough during bronchoscopy, so another aerosolization, adding it to the bronchoscopy, which is aerosolizing procedure. Moreover, the bronchoscopists usually use the nasal route for bronchoscopy under sedation. So nasal route, high viral load, bronchoscopy aerosolizing, high oxygen flow aerosolizing, and coughing another aerosolizing. So a lot of aerosolization there. So if you want to avoid all that, you may want to think about general anesthesia for these cases. So in summary, bronchoscopy is a aerosolizing generating procedure, jet ventilation, high flow, even nasal cannula, 5 liter or more are also aerosolizing. Preoperative COVID testing for all, as we discussed the caveat for that. Use ETT when feasible, avoid coughing, PPE use, and consider general anesthesia versus moderate or deep sedation for bronchoscopy. And many of you know, with my association with Society for Head and Neck Anesthesia, I'm currently the immediate past president. A lot of information about airway and bronchoscopy and over there. If you'd like to learn a little bit more about what they offer, at shanahq.com. But before you go there, you have to visit sambahq.com. You got that? Or .org, I meant. sambahq.org. Thank you. With that, I will conclude my presentation, and it is my great honor to present to you my friend and colleague, Dr. Mark Phillips, who is the Associate Professor of Anesthesiology at University of Alabama at Birmingham, and the Director of the GI Endoscopy Suite, who will be taking the screen and start his presentation now.
Good evening, everyone, and I appreciate everyone joining us for the webinar this evening. I appreciate Basim asking me to present. I'm going to talk a little bit about our experience at UAB and anesthesia for GI endoscopy in the setting of COVID-19. I have no financial or pharmaceutical relationships to disclose. One thing I will disclose is information and recommendations regarding COVID-19 is dynamic and changes rapidly. In previous meetings and manuscripts, I look back over several years worth of papers and researching for a talk or writing something. For this, I would look at something from March and go, well, that's completely outdated at this point. Let's see if we can find something from last week. And this information is coming at us very rapidly and changing very rapidly. I told someone the other day, I feel like I've done another residency in just the last couple of months as we've geared up for dealing with this novel coronavirus. So a little bit of the goals and objectives I'd like to talk about this evening. I want to discuss some of the changes to GI endoscopy anesthesia practice related to COVID-19, our experience in reopening and ramping up cases, a little bit about scheduling, pre-procedure assessment and testing, some of the logistics we deal with, a little bit about personal protective equipment, and some of the things that we're doing with anesthetic management. A little bit about our endoscopy here at UAB. The UAB Hospital Advanced Endoscopy Unit, we do about 4,000 cases a year there. Probably a mixture of 70% outpatient, 30% inpatient. We do everything from ERCP to EUS, double balloon enteroscopy, radiofrequency ablation for Barrett's esophagus, the whole gamut of advanced endoscopy procedures. We also do some upper and lower procedures, mostly for inpatients, but we do some, like I say, upper and lower endoscopy and colonoscopy. We do 4 procedure rooms there that are anesthesia staff. 2 of those rooms are fluoroscopy rooms. We do not have any negative pressure rooms in our hospital-based endoscopy suite. We also have the Kirkland Clinic, which is our outpatient clinic where patients come for office visits. The endoscopy suite there does moderate sedation cases only. We're not involved with any of the cases there. They do mostly upper endoscopy, colonoscopy, paracentesis, liver biopsy, some esophageal dilations, those sorts of procedures. We also have another hospital, UAB Highlands, a couple of miles down the road, and we do moderate sedation there, there's one practitioner that works there. So as you can see, we have a wide variety of endoscopy locations and procedures. I'm going to mostly be talking about things that we're doing at our UAB Hospital Advanced Endoscopy Unit. So reopening and wrapping up cases. We closed our unit on March 16th in order to gear up and prepare for the cases that we thought were coming, in order to prepare and have personal protective equipment available, have personnel available, and free up bed space. So fortunately, we were never hit with the surge of cases that kind of was projected that we would, and all over the course of COVID up to this point in Alabama, we've had 7,600 cases. There's been about 288 deaths in the state. So fortunately, we have not taken a horrible toll like some other states. We cleared up several hundred beds in the hospital, and a lot of those remained empty. I think our maximum number of COVID patients at one time in the house was 65, and maybe about 30 of those on a ventilator. So as I say, we weren't hit terribly hard, but we did cancel a great number of cases, both in the main OR as well as in our endoscopy center. So our certified nurse practitioners that work in the GI area, they kept a list of kind of the highest priority cases that we would need to do as we reopened. And as we began ramping up last week with some cases, and then this week adding more, those that were triaged as needing a procedure within 14 days were the first priority. They were called and scheduled. We began, as I said, kind of slowly last week, and then began adding more cases this week. Of course, the ramp up in cases depends upon local rate of infection, what the hospital resources are. Possible increase in cases related to reopening the economy may cause a need to decrease elective procedures again. That will be kind of a fluid thing as we begin to reopen the economy. One impediment for patients coming is fear of coming to the hospital due to the fear of COVID-19. I think Basim mentioned something of this, and it's a real fear people have. Somebody mentioned that they were told that, well, I don't want to come to UAB because that's the COVID hospital, being the largest academic medical center in the state and a major tertiary referral center. Of course, we are the hospital that got the most serious of those cases. So it's a real marketing effort that our marketing people are gearing up for, to allay that fear and let people know what we're doing to keep them safe and make it safe for them to come to the hospital. So that's something that hospitals are going to really need to do, is work on that marketing aspect to lessen the fear that people have. It's important that we resume these procedures in order to lessen morbidity associated with canceled and delayed procedures. Somebody who had a pancreatic lesion that didn't get diagnosed in time and now has inoperable pancreatic cancer. Somebody who didn't get their heart surgery done on time and now has a heart attack and is left with severe left ventricular dysfunction. So there's all these things that can occur because of not doing these cases. So that's, again, important that we begin doing them. Pre-procedure assessment. Prior to COVID-19, our patients had their anesthesia pre-procedure assessment done after arrival to the unit. With COVID-19 closure, we were still doing some urgent outpatient procedures, and we did these via telephone pre-procedure assessment. With reopening the unit, we're going to continue this telephone pre-procedure assessment and a physical exam done on arrival. Part of the phone assessment is screening for any symptoms of COVID-19, including a travel history, as well as arranging for testing. Now, the travel history was in some of the earlier recommendations, but now that no one has been traveling for the last couple of months, I don't know that that's really pertinent, because most of everyone's travel during the era of COVID-19 has been from the living room to the refrigerator. So not much travel going on lately. At this time in our COVID-19 testing, patients who are scheduled for a procedure go through testing for COVID-19. As Basim mentioned, asymptomatic patients can shed the virus before onset of symptoms. Currently, patients are scheduled for testing at our facility within 72 hours of procedure and then told to self-isolate after the test performed. This process has led some people to cancel. We draw from a large catchment area. We're an open access unit. A lot of our patients are new to UAB. They may live several hours away on the Florida Gulf Coast or northern Mississippi, Tennessee, and they cannot afford to drive multiple hours to come in to get a nasal swab and then go back home, or cannot afford to stay in the hotel for 2 days until their procedure. And we hate to lose that, because when you lose that business, you lose then if it's a US FNA and they diagnosed with pancreatic cancer. If they don't get that done, then you're not going to get the Whipple or the chemotherapy, so you lose downstream business. So we want to make it so that people can have ease of access. We're working on having local, reliable sources of testing, but in some of these smaller areas, the turnaround time on that is still several days, longer than the 72 hours that's our limit. So as I mentioned, it's still a problem in that. Our turnaround time with a PCR test here in our lab is a matter of hours, not days. We have a limited number of Cepheid tests, and the turnaround of that is about 45 minutes. As I mentioned, we have a limited number of those, but because of our need to have quick turnaround for patients who just cannot get here for testing, pre-procedurally testing, we do have some that are now reserved for our endoscopy patients. I think as the time goes on, the point of care testing, these quick tests like the Cepheid test, those are going to become much more readily available, and this will begin to be a problem that doesn't really exist anymore, as we'll have much more rapid testing. So patients who test positive for COVID-19, they're canceled unless it's deemed an urgent or emergent procedure. Anybody who has a positive COVID-19 test is not done in our endoscopy suite. Positive COVID-19 patients have their procedures done in the main OR in a negative pressure room. So a little bit about logistics. Patients arrive with a driver. Masks are worn on arrival for everyone: the driver, the patient, all our nursing personnel, all our personnel in the hospital are masked at this time. They arrive to our Kirkland Clinic area, where temperature and screening for symptoms is done. If that's all good, then they're brought over to the endoscopy suite. The driver stays in the waiting room. The waiting room has been arranged for social distancing. I took a picture there to show we got one chair that says "Don't sit here," and it's turned around, and a chair there for the accompanying person to sit in. We haven't removed all those chairs because, as you know, at a hospital, if you take something out, it's gone and you'll never find it again. So we've left those there for hopefully someday when we can once again have visitors and more than one person with the patient. Employees are temperature screened each morning. We have not really extended our time between cases, and we're basically doing the disinfecting in the procedure room after in between procedures that we had been doing before, because the procedures that we had been undertaking kill coronavirus just as they do the other organisms that might be in the procedure room. So a little bit about PPE. As mentioned earlier, endoscopy cases are aerosolizing procedures. Viral particles are detectable in stool. Often positive stool tests are found after respiratory tests are negative. Currently, our practice is to wear N95 mask, face shield, gown, and gloves. N95 masks are reprocessed daily, so we can get numerous uses out of them. With negative testing and negative symptoms, we feel fairly confident that patient does not have COVID-19. However, as Basim mentioned, the test is not perfect. Anesthesia provider, endoscopist, and tech are in close proximity to the oral opening, so we feel that this use of PPE is appropriate because of these aerosolizing procedures and the fact that someone may actually be positive that was not. Wearing PPE is very appropriate in these procedures. Donning and doffing of PPE has a whole protocol associated with it, and this should be done in following recommended practices in order to not contaminate or risk contaminating yourself as you're doffing the PPE. A little bit about anesthetic management. As I mentioned, COVID-19 positive patients have procedures performed in the main OR in a negative pressure room. They wear full PPE, and usually, almost always, that's with a rapid sequence induction of general endotracheal anesthesia. In our procedures done in the hospital endoscopy suite, these are done with anesthesia as indicated for the procedure, as we would do anytime. If we are doing cases with sedation, currently these patients are COVID-19 negative within 72 hours, that are COVID-19 negative within 72 hours of the procedure, negative screening on admission. It is not felt that all these patients should have general endotracheal anesthesia. There are problems associated with general anesthesia, such as an unexpected difficult airway or hemodynamic instability. So we don't feel that we need to do general anesthesia on all these cases. Avoid high-flow nasal cannula. Avoid local anesthetic sprays to the oropharynx, as Baza mentioned. Limit the people in the room during induction and extubation if it is a general anesthetic case. It's also recommended to follow up phone call at 7 and 14 days just to see if someone turns positive, and then you might need to go back and check the people who are in the room. One of the things that we've begun using during this time is a procedural oxygen mask, or the palm mask. And it's useful in upper endoscopy procedures. It provides a higher FiO2 than nasal cannula. The medium concentration mask will provide an average FiO2 of 80% at suggested flow rate of 8 to 10 liters per minute. The high concentration mask will provide an average FiO2 of 90% at a flow rate of 10 to 12 liters per minute. One of the advantages of this over the nasal cannula, besides just the higher FiO2 that's available, is that it does provide some sort of mechanical barrier if patients call for retch during a procedure. As you can see here, there's a port that opens to allow the endoscope to be passed orally, or a port here in case it was a nasal intubation or something like that. There's a place here for end-tidal CO2, and then the oxygen comes in from the side. So it's not, I couldn't find a study discussing the decrease in aerosolization if this is used versus just a nasal cannula, but it stands to reason it would decrease significantly the amount of particles if the patient was coughing or retching during a procedure. And there's a picture showing it in use, the higher concentration on the right with a non-rebreather bag, and then with the oxygen supply tubing on the one on the right. So, you know, as I mentioned, we don't do a lot different with our anesthetic management in these cases. We are much more careful with using personal protective equipment and using the procedural oxygen mask if it's a case done under sedation. And so, you know, the gamut of sedation is available to us. And as I mentioned, we do not do COVID-19 patients in our hospital-based endoscopy suite. Those are done in the main OR. And here's just a picture just to remind us that social distancing is one of the most important things we can do in order to remain safe. The picture on the left is a beach in Texas over this past weekend when it was reopened, and definitely not doing any social distancing there. The picture on the right is my son today was on the beach in Cape San Blas in Florida, and as you can see, very few people there, so social distancing in place. I appreciate the opportunity to talk with you today to discuss a little bit about our practices ongoing at UAB, and hope you picked up a little bit that'll be beneficial to you as we begin ramping up and reopening our procedural areas for the cases that we have. Thanks very much.
Thanks, Mark. Very much appreciated. Appreciate this informational talk. And now it's my pleasure to present my friend and colleague, Dr. Niraja Rajan, who is the Associate Professor of Anesthesiology at the University of Pennsylvania, Milton Hershey Medical Center, where she's also the Director of the Hershey Ambulatory Surgery Center. Niraja?
Thank you, Bassam. Thank you for the opportunity, and thank you, Samba, for all the guidance during this time. So I'm going to talk a little bit about, as we start to ramp up, how are we going to take care of pediatric patients in the ambulatory setting and the NORA setting. So I'll be talking a little bit about MRI, cath lab, bronchoscopy. So just a little bit about how are kids different compared to adults in terms of epidemiology. Well, kids tend to have milder symptoms and better prognosis. They also tend to spread the virus when they have the milder symptoms. So you may not recognize that a child is ill, and they may still be shedding the virus and therefore able to spread it much more than adults. Transmission is similar, respiratory droplets and aerosols. But in the case of kids, it's close, prolonged contact. So kids, when they get infected, it tends to be a cluster of cases. The interesting thing that I read about kids as well is the fecal and urine aerosol transmission occurs for longer than the respiratory transmission. So kids potentially play a major role in community-based transmission of COVID-19. So incubation period ranges from 1 to 14 days, mostly 3 to 7, and particularly in children, in up to 2/3 of the cases which test positive, there's a viral co-infection. Kids also tend to have, in addition to the usual symptoms of fever, dry cough, and fatigue, they have upper respiratory symptoms such as nasal congestion, runny nose, and sore throat, which a lot of kids typically have on a regular basis. So it's hard to distinguish if they're COVID symptoms or just a regular URI symptom. Kids also have atypical symptoms such as vomiting and diarrhea. So just some non-specific lab findings on blood tests. They tend to have elevated liver enzymes and LDH, low lymphocyte count. And when you do the SARS-CoV-2 nucleic acid test, you can sample it from the sputum, blood, feces, or anal swabs. So there's several ways to get the sample. As far as the antibody test, I know Bassam and Mark both talked about it a little bit. So you detect either an IgM or IgG. And again, antibody test is not to be used for triaging patients. It's just an indicator of past infection, and not everybody seroconverts, so it's not very reliable. Kids also display specific findings on spiral chest CT. So that has been used to diagnose some of the harder to diagnose cases when they present with other co-infections and other viral infections. A spiral chest CT has sometimes been done to identify COVID. So high-risk children tend to have more severe disease, and these high-risk children are children who've had contact with cases with severe COVID-19, or children with underlying cardiac or pulmonary conditions. Ex-preemies would come to mind, kids on immunosuppressants, and kids under 3 months of age. So what are some of the logistics to consider when you're looking at pre-procedure? So some of it Mark was mentioning about scheduling. So we've had very few elective cases in the last month. Our volumes were down to about 20% of what we typically do. Now that we're starting to ramp up over the next few weeks, we're looking at prioritizing cases based on acuity. And these are cases that have been put off now for about 6 to 8 weeks, and some of them cannot be put off any longer. So they've now become essential procedures. So when you look at your scheduling as you start to ramp up, you want to prioritize cases based on acuity. As far as screening, you should still follow the same guidelines that have been given out by ASA and SAMHBA regarding everyone gets a questionnaire that asks them about potential exposure and potential symptoms of COVID-19. And then this is repeated when they arrive at the center. And also everyone gets their temperature taken before they're allowed to enter the center. So some things that are interesting about kids, which are different from adults, is it's easy to screen an adult. And it's also easy to tell an adult, your visitor can't come in with you. They can wait in the car or they can wait at home and we'll call them when you're done. Can't possibly say that to a 2-year-old. So you're gonna have to have one visitor accompany the kid the entire time that they're at the center. So that brings about a new twist in this, so to speak, because the visitor could be an asymptomatic carrier or in the early stages of infection. And we're not really screening visitors in terms of we're not testing them and we're not requiring them to remain at the center. So if the kid's parent is required to remain at the center, we should think about maybe screening them like we do a patient and getting their temperature before we admit them into the center, and also give them a level 3 mask to wear rather than the homemade cloth mask that we're allowing them to wear currently. So that's something to think about when you're starting to do kids. The other thing is when you call them, you let the parents know that this is the process for screening and that you would be following whatever process it is for testing so that they're not caught by surprise. So like I mentioned before, the visitor policy, we typically used to tell the parents of kids that one parent must remain in the building the whole time. So now what we're going to be telling the parents of kids is only one parent may accompany the child to surgery and then may remain with them in the building the whole time, but no siblings are permitted and no other relatives, just one adult with the patient. So that's a little bit different than what we've been doing in the past. For the day of surgery screening, like I mentioned before, temperature taken for both the parent and the child before they're allowed into the center, and both of them wear masks. So as far as wearing masks, I looked at the American Academy of Pediatrics, and they recommended that anyone over the age of 2 be required to wear a mask. I don't know how this is going to go over. It depends entirely on the emotional maturity of the 2-year-old. Some of them would probably be okay wearing one. Others, I don't see that going very well. So that's something you need to think about when you start ramping up kids. Some of them are not going to wear a mask. As far as the waiting room, we do have heightened cleaning of the waiting room. So it's cleaned approximately every hour. Surfaces are wiped down, doorknobs, door handles, etc. We have enough time between cases to permit for both social distancing so that not a lot of people are arriving at the same time. We stagger our arrivals so there's not a lot of people in the waiting room at any given time. All toys and potential fomites have been removed from the waiting room, and there's adequate seating space for social distancing, or parents are asked to wait in the car. The parent is asked to wait in the car. As much paperwork as possible is completed ahead of time using televisit, and then in the car so that they spend as little time as possible in the center. Mask use, like I mentioned, both the parent and the child are required to wear a mask. There is no food or drink in the waiting room, just to prevent any contamination. So to test or not to test, ASA and APSF put out a statement and SAMHBA put out a statement about testing. So Bassem actually went over that already. And what I would say is when you start to test the kids, consider the fact that testing is, recommended 72 hours before the procedure, up to 72 hours before the procedure. So typically you would tell the adult to self-isolate after they tested so they don't acquire COVID-19 from somewhere else, but you really can't feasibly do that with a kid. They are going to be running around, they probably have siblings at home, and they're probably in close contact with other adults that live with them. So it's going to be difficult to predict if the kid has truly been isolated since the test. And given the 30% false negative rate with kids with testing, I'm not sure we can completely rely on a negative test. So you would continue to use PPE, and you would continue to use all of the precautions as if they were an asymptomatic carrier of COVID-19. Testing also depends on the community transmission rate. So the ASA statement states that if the community transmission rate is low or negligible, that you don't have to test everybody. Currently, I don't believe that there is any community with a low or negligible transmission rate, but that might eventually come to pass, and then testing could be foregone in that situation. The other thing that ASCs and other centers need to consider is the feasibility of testing and the costs and the risks involved with testing. So this may not be feasible in a small surgery center to offer this type of testing. And some of the rapid testing with the 45-minute turnaround may not be possible at all in a surgery center because you need trained personnel to obtain the specimen. And I see a lot of can of worms, essentially, if you bring that up with the ASC staff, because they are not really trained lab technicians. Another thing to consider that's been brought up is an informed consent that specifically deals with patients getting elective surgery during a pandemic, and you inform them that, you know, they are aware that they're getting elective surgery during a pandemic and that there may be a slightly higher risk involved with that. So that's another form we're considering at our center. So pre-procedure, what are some of the things we do? We were previously starting IVs on all kids 8 years and above. It's now time to consider extending that to maybe 5 years and above. The reason being, if you imagine a mask induction in an uncooperative child, there's going to be a lot of aerosols being generated. So if a child is cooperative enough and you can use other distraction techniques in a pre-medication and get an IV started, it would smooth the process of induction, possibly less aerosols generated. I also want to say that if a procedure is high risk for aerosol generation, it should be performed not at the ASC, but at the main hospital or in a negative pressure room. As far as pre-medication, you don't want an uncooperative child crying all the way back to the operating room. So I would recommend pre-medicating if it looks like the child is going to be uncooperative or you're foreseeing any problems getting them to separate. And finally, parental presence. Now, parental presence is a can of worms during the COVID era, because you're now letting another person accompany the kid back to the operating room that has not been tested and will remain for induction and potentially be exposed to aerosols from their own kid, but exposed to aerosols nevertheless. So you want to consider, how are you protecting the parent when you get them back? Because we're all wearing N95s, but is the parent going to be given an N95 if they come back for induction? And the other thing you want to consider is, are you going to allow an untested individual back in your operating room? So I just want to throw this out there just to cause some controversy. Intraoperatively, the induction room is a nice concept in places such as MRIs or cath labs, because these places have air exchange times of 79 minutes. And unlike the operating room where the air exchange time is 21 minutes. So theoretically, if you've extubated somebody in an MRI scanner, you wait 79 minutes for all of the air to be exchanged and all of the potential aerosols to be cleared from the room before you can bring the next patient back into the room. So in the interest of saving time, it's worthwhile considering an induction room, which would have an air exchange time similar to an operating room. So you could induce the patient in the induction room and then take them into the scanner so that the scanner is now not exposed to aerosols. This would also facilitate cleaning of the scanner between cases. And remember, these off-site locations are not operating rooms, so they don't have the same type of cleaning protocol that operating rooms have. They're not used to mopping the floors between each case, which is what they're required to do if there's an aerosol generating procedure in there. So you want to consider having an induction room, which would definitely speed up the process. The type of airway, I'm not too sold on one type over the other. I'm perfectly open to using supraglottic devices or an endotracheal tube, just as smooth of an induction and intubation as possible, and spontaneous ventilation whenever possible, and that would minimize aerosol generation. I wanted to bring up the talk about viral filters to protect the machine. So most circuits have a humidifier and filter, which you can place on the expiratory limb, but depending, the efficacy usually tends to be 99.99%, and we don't know currently if they're effective at filtering the SARS-CoV-2 virus. So the APSF recommends 2 filters. So the second filter would be placed between the expiratory limb and your anesthesia machine. So a lot of machines have air traps that also have viral filters with a 99.99% efficacy. However, depending on the type of machine and how the gas is sampled, if the gas that's sampled is returned to the circuit, then you need an additional filter to protect the machine. So some of the people have been using epidural filters, because that's another 0.2 micron filter with a 99.99% efficacy rate. So that could be your second filter. I still recommend using PPE for all aerosol generating procedures, and that would include intubation and extubation. And then I recommend doing high risk aerosol generating procedures in a room that's equipped with negative pressure. Also consider wait times in between. Like I mentioned before, the air exchange time in MRI and cath labs is 79 minutes, not the 21 minutes. Post-operatively, you want to think about the recovery area. You don't want to crowd kids in the recovery area. You want to have adequate spacing between the kids, and preferably a closed recovery room, because kids will cry when they wake up. Some of them are going to have PONV. Some of them are going to have emergence delirium. So your anesthetic plan should include aggressive PONV prophylaxis and prevention of emergence delirium. So that's something you want to strongly consider when you're taking care of kids. As far as the visitor policy, unlike adults where we give them instructions over the phone and then get the patient ready and take them out to the curb, we can't do that with the kids. The parent has to come back to recovery room. So that needs to be kept in mind. Make sure the parent's wearing a level 3 mask, and make sure, if at all possible, have a closed recovery room where you can recover these kids separately from other patients. Okay, so to summarize, I talked a little bit about how COVID-19 is different in kids, some special considerations for anesthesia, and some special NORA considerations. And may the 4th be with you.
Thank you very much, Dr. Rajan, for a very informative presentation. I would like to ask all the speakers and panelists, Dr. Hinda Abramov, to turn your cameras on. We reached actually our end of our webinar, 9:15. However, I would like to take a few minutes to continue the recording, since we have the speakers with us, to tap into the knowledge. We received about 27 questions. We'll answer a few tonight, just a couple to make use of our speakers here, and then the rest of them will be tabled for next webinar, which is all things COVID town hall, where we're going to answer a lot of these questions. So, Dr. Abramov, regarding interventional radiology, what are your thoughts about COVID cases under sedation in IR? Is that something they usually do?
Yeah, they do, and they do it frequently. One thing that's obvious to me listening to the speakers tonight, and just from my own experience, is that there's no one way to do anything, since there's no evidence regarding anything. So, you know, we're currently, for example, in GI, we are currently intubating everybody and not doing sedation cases. The interventionalists are doing lots of sedation cases on COVID positive people without anesthesia. So, you know, if we're able to do it without overly sedating patients where they're going to require high flows, nasal oxygen, or chin lifts and that sort of thing, then there's no reason why we can't do them under deep sedation. On the other hand, we do tend to have a low threshold for intubating patients, because the worst situation is if you're in the middle of something and then have to intubate somebody, because then it's totally uncontrolled.
Clarification, those are non-aerosol generating procedures, correct? That were done under procedural
No, but the
sedation
patients are under sedation and they're breathing, you know, yeah, no, not aerosolizing procedures.
Got it. And I know you have multiple rooms in your unit. Are you allowing COVID positive patients to go to any room anytime?
We
Or
no,
do
we
you
have a
restrict the
dedicated,
cleaning
we
after?
have a, assuming that we know, because up until recently we weren't testing everybody, but assuming that we know who's COVID positive, we are putting them in, we're trying to put them in one location, because that room, particular room, has less equipment and covered anesthesia machines, and, you know, less chance of cross-contamination.
And there was a question from one of our audience about cleaning after a COVID positive patient. Is there any difference cleaning the OR compared to the regular procedure without COVID positive patient in the room?
AORN has a document on this if you want to go look that up. And I would just say make sure you're using a EPA recommended cleaner that's effective against SARS-CoV-2. And what we've done additionally, a lot of places do not mop the floor between cases. So that's something we've added, mopping the floor between cases and allowing it to dry. But other than that, we do clean other surfaces as AORN recommends. So AORN actually has a very nice chart on this, so you can go look that up. It's available.
Thank you. We have lots of questions about cataract and a couple of questions about the other procedures that we're going to address next week. However, we have many questions for Dr. Phillips. There are about 3 or 4 questions about one item, which is how long would you wait between cases to let the droplets and everything settle? Some people saying we heard an hour in our hospital. Some people said longer. So what's your take on that, please?
In our GI suite, where we are doing only COVID negative patients that are asymptomatic, so possibly, you know, with the false negative rate, there could possibly be someone who is positive, but we feel pretty good about, with our symptom screening and temperature screening and the negative tests, that they're COVID negative. So we don't wait any significant period of time in between. If we waited an hour and a half in between cases, we would have no productivity whatsoever in that suite. Now, in the main OR, when there is a COVID positive case, there is a period of time that they wait before cleaning the room for droplet dispersal. But in our endoscopy suite, we're not waiting in between. We're probably not as fast as we were pre-COVID. We're not as busy as we were either. We're doing now 12 cases or so a day, 15 versus 30 previously. So we're not as quick with our turnaround times, so we're not waiting a particular period.
Yeah, I'd have to say at the clinic too, and the consensus is in the rooms that don't have fast air turnover time, that we're not waiting either. We're just counting on the cleaning process to work.
All right. So there's a suggestion from Dr. Rodriguez, our president-elect, for this person who asked a question. If you post it on the forum, he will be willing to post an answer for it. And my take on it is that please consult with those folks who manage air handling in the operating room or the procedure room. I just saw an article about them being underappreciated and unrecognized. They do a lot of hard work for us, and they probably know a little bit more about how to handle the air and circulation in our hospitals. I heard, for example, it takes an hour in one room in some rooms, and I heard it takes 4 minutes to circulate all the air in one of our operating rooms. So it's variable depending on which system we use. So I would check with the air handlers who know more about the hospital air. Let us know about what is a safer approach. And I think the question addresses those who are asymptomatic carriers that we are not aware of. Another question for Dr. Phillips. Do you use the same N95 mask the whole day, or do you change it between cases?
With our, shortage of N95 masks, we're using the same mask throughout the day, unless it becomes soiled. Some people are wearing an additional surgical mask over the N95. That's not universal. Some people are doing that and then changing that in between cases, but we're using the same N95 unless.
The other question is that if you do not have negative pressure rooms in a freestanding GI facility, how do we effectively manage risk of COVID exposure for patients from case to case? Anybody use any question? The continuation of the question, ultraviolet, would that be helpful for disinfection? Was there another method of disinfecting the air in the room?
Not that I know of. I think if you're in a freestanding center, again, I think testing is important to do. Again, each location and region is different as to what their testing capabilities are, but I would certainly recommend testing and then symptom and temperature check on the day of arrival. If you don't have a pressure room, you don't have a negative pressure. And if you have a known case that's positive, I would do them in a place that does.
There's a question for any of you to answer about reusing intubation blades, intubating blades. Is it safe now with COVID-19? Or what kind of cleaning would we do for these blades, intubating blades?
Joint Commission, if you actually look at your laryngoscope, if you look at the handle and the blade, none of us are following the recommendations on how to clean the handle between. You're supposed to clean the handle between each case, which means you take the whole thing apart, you remove the batteries, remove the bulb, and then it gets processed and it comes back and then you put it back together. So we recently switched to all disposable just because of that, because the Joint Commission is really looking at this. So you either want to make sure you have an answer for them when they come to your center that you're actually processing this blade and the handle between each patient, or get a disposable. So that's what we have. We have disposable laryngoscopes and equipment.
Thank you. There are a couple of questions about testing I'm happy to handle. One of them saying that we are trying to do it within 48 to 72 hours, but our turnaround time is not making that possible, and the primary care physician is not willing to clear them for the procedure unless they see the COVID test results. Can we do it within 7 days? Well, what we listed in SAMHSA policy or SAMHSA statement is what to guide you, what is the best case scenario and the rationale and so forth. Now we have to work with what we have available in our area and so forth. So if 5 days or 4 days is what's working for you, then so be it. But also remember that we have to instruct your patients to self-isolate and avoid exposure as much as possible, and still continue to screen for symptoms and so forth till they come to you. And as things move forward, there are going to be more testing available, more of the fast test available, then we can switch to that. So as Dr. Phillips alluded earlier, that this is a fluid situation. Things are changing, things are improving, more PPE are more available, testing is more available, the numbers are going down, we're learning more about the virus, we're having treatment availability and hope coming in our way. So there's a lot of things changing. So we posted this statement based on the best available evidence, based on the best available knowledge that we have, based on common sense, based on experiences and consensus from experts. So please use that for the spirit for which it was presented to you, and to get the best scenario for your patient. And many folks actually have this, but they don't feel like they should do it or do it. A statement like this would help you with your discussions and negotiation with the ASC administrators and directors to get that, or even make an extra effort to make that available. Which is probably the right answer for the next question, which is say, how do you reconcile the difference between the much more realistic GI Society's statement to screen everyone and test anyone with positive screening, and the SAMBA guidelines to PCR test everyone within 72 hours for a small non-hospital-based practice? Well, in their assessment and judgment, that was what they thought is safe and appropriate. We kind of agree to disagree on that. We posted what we believe is the best approach based on the current state of knowledge and information, and for which we strive to achieve and try to get there by working through your channels and your communities and local authorities, and to make these tests available and try to figure out a workflow for your patients to do that. When there are some delays or this or that, then things that you can work out. Mark explained some things that he did in his hospital. Others can do different things. Our ingenuity and mental capacity and power will be able to solve a lot of situations like that. Well, it's 9:27, so we'll answer a couple of questions and then we'll close it and call the night. Does LMA insertion carry same risks as tracheal intubation and extubation? Anybody have information on that, please? I personally have not seen any evidence to speak to one or another. There was another question about would trying regional anesthesia and moderate sedation reduce risk? I can answer that a little bit. See, it depends on what the situation is. If you're using a regional anesthesia and you're using mild sedation with it, that would only require a liter, no oxygen, or 1 or 2 or 3 liters of oxygen. That's one thing. When you do regional anesthesia and use heavy sedation with propofol and such requiring 10 or 15 liters of oxygen, that's aerosolizing. And then if you have to do airway support maneuver, that would bring your face closer to the patient. So that would put you at a higher risk if this patient indeed have virus and aerosolizing. Moreover, if you have to intubate emergently, somebody with sleep apnea and such, and you end up over sedating and this and that, then would be a situation where you're going to do it emergently under uncontrolled situation. That would increase your risk. If you're doing regional for redo hip, for example, and you know that's going to take longer time, and then you're going to face that situation later, then you probably want to do some different upfront. So it depends on the situation, depends on the regional anesthesia technique. If it's something that works 100% of the time or 99% of the time, or it doesn't work in emergency intubation and such, or heavy sedation, high flow of oxygen, and so forth. But if you're able to do regional with no to little sedation with small amount of oxygen, that might actually work and avoid manipulating the airway at all. Dr. Phillips, do you make exceptions for general endotracheal anesthesia and upper endoscopy? If so, how do you make that determination?
But what do you mean by, could you restate that question one more time?
It says, do you make exceptions for general endotracheal anesthesia and upper endoscopy? Meaning, the way I understand is that, do you intubate every upper endoscopy? If so, how do you make that determination if you do it with general endotracheal anesthesia versus sedation with whatever palm mask or other techniques?
We basically are doing, choosing our anesthetic plan based on what does the patient need. If it's a food impaction, if it's a gastric outlet obstruction, something of this nature, a difficult airway that we might want to proactively manage, morbid obesity or supermorbid obesity that we would feel dangerous doing sedation with, then we do an tracheal intubation. If it's a routine upper endoscopy, then we're managing that with sedation. So we haven't
Thank
really
you very much.
made significant changes in how we manage that.
I appreciate that. I would like to take this as 9:30, so I'd like to take this opportunity to thank all our panelists and speakers for a job well done, and thank you all for joining us for this webinar tonight. The recording of this webinar will be available, I believe, tomorrow, if not after tomorrow, on our website with the slides and so forth for you to review and enjoy. And please make plans to join us next week's webinar on Monday. We have many questions that we did not have time to answer tonight. We will use those. If you have additional questions, please bring them as well with you or send them to us so as we can prepare the answers for it. And I did not forget, we did have 2 questions that we did not answer from last time. We'll address those as well. So we'll look forward to having you again with us next week. And good evening. Take care, stay safe, and God bless. Bye-bye.